Endometrial cancer, a very serious problem, and today we're going to talk about what it is, who gets it, how to find it, how to treat it, what you can do to maybe even prevent it. Welcome to Talking with Docs. I'm Dr. Brad Wheeler.
I'm Dr. Paul Zalzal.
We have a special guest.
I'm Dr. Tiffany Zegras,
a gynecologist-oncologist who specializes in treating this kind of a problem. Thank you so much for coming.
Thank you for having me.
We really appreciate your expertise, and so will our guests. And if you have a comment, please leave it. Share your experience with endometrial cancer, because our viewers often will read the comments and it really helps guide them along their journey and help them not feel alone. So
it's not just our viewers now. We now have listeners.
Listeners, yes. So yes, we have a podcast.
This is actually going to be on a podcast.
Oh, that's great.
Yeah. There you go. You can see us, listen to us.
Yeah, it works.
Paul always said I had a face for radio.
I said I got a face for podcast.
There you go.
Because a lot of our viewers, wanted to listen to it while they were on their stationary bike going for jogs.
Okay, yeah, that makes sense.
Exercises.
I do most of my podcast listening in the car.
There you go.
There you go. Okay, so let's start at the beginning. What's your endometrium? Why is it a problem?
Oh, fantastic question.
Okay.
So the endometrium is actually the lining of the uterus, or the uterus or the womb. That's where a baby would grow in a person who has a uterus, or usually women.
Okay. Yeah. Fair.
And so the lining can grow abnormally,
right.
And can cause bleeding.
Right.
And if that happens, then we have to do a biopsy to figure out if somebody has either a precancer or a cancer of the lining of the uterus.
And like so many cancers, cells that turn over a lot are more susceptible to essentially making mistakes and having a tumor grow. And the uterus turns over, or the lining turns over every month, right?
Yeah.
That's what menstruation is the sloughing of the endometrial lining. That's what results in menses. So this is why it's an issue.
Exactly.
Okay, so let's start then. Who gets it? So obviously someone very, very young is very unlikely to have this.
That's right. Yeah. It's not very common in young people, although it can happen. So if you are having abnormal bleeding, then we do recommend that you see your healthcare provider and ask for an endometrial biopsy, because even sometimes healthcare providers don't think about it because it's not very common in young people. So they don't think about it as
it's written off as menstruation.
That's right. Or a problem with bleeding or irregular period or hormone problem, but it can be present in a small number of people who are young. So
ballpark, how many people, say in Canada, would be diagnosed per year?
About 8,600 people are diagnosed in a year with endometrial cancer.
And then of those that don't make it?
It's about 1,600 people who die every year of endometrial cancer.
That's Canada numbers. If you're in the US, roughly times these numbers by 10 because of the population differences, but I think it's around 70,000 diagnoses in the US per year. So it's pretty significant.
It is, yeah. Most people are diagnosed after menopause, so they stop having bleeding altogether, right? That usually happens around 50, 52 years old for the majority of women.
Yes.
And then they might have some spotting.
So is this the number one way that they present?
This is the number one way.
Painless bleeding.
Painless bleeding. And actually, because of this painless bleeding, we pick these cancers up usually pretty early. So I would say somewhere between 70-80% of people are diagnosed in stage 1 because they have a symptom.
And because it's a menopausal woman, it's like, I haven't had a period for 3 years.
Exactly,
And now all of a sudden I'm bleeding.
A lot of people will say, oh, I just had a period. That's weird. And it is weird. It shouldn't happen. Go see your healthcare provider. You'll need an endometrial biopsy. They may also order an ultrasound to measure the thickness of the lining. That will also check the ovaries and just make sure, is there any concern for any spread? An ultrasound can see that in a subtle way. You might also get a CT scan depending on the findings from your doctor.
So that's a silver lining a little bit, that endometrial cancer does present early with a symptom that you can see. So don't ignore that symptom. It's giving you a heads up. But now, not all painless bleeding postmenopausal is uterine cancer, right?
That's right.
There's other causes.
There's definitely other causes.
But other causes that could be bad or could be benign, but you should get that checked out right away. Okay, so who gets it? We said it's usually postmenopausal.
Usually postmenopausal women.
Any other risk factors?
Yeah, often people who are overweight, obesity is linked to endometrial cancer. And for a very small number of people, it can be linked to a genetic abnormality called Lynch syndrome. So these people actually are at high risk of colon cancers and uterine cancer. So if you have a family history of colon cancer, you might want to ask your family member if they ever were tested for Lynch syndrome, and then you can also be tested.
Is it a genetic test?
It's a genetic test. That's right. Yeah.
Okay. So obesity, and that I would call that a modifiable risk factor.
That's right.
If you're struggling with obesity, here's another reason that you may want to get that under control, because it is a risk factor for this and other cancers.
That's right.
Is the reason because of peripheral conversion of estrogen and that kind of thing?
That's right. Yeah. So it's the unopposed estrogen. So in our fatty tissue in our body, we actually make estrogen.
Right.
And so if we're overweight, then we make more estrogen. And it's that unopposed estrogen, meaning like too much estrogen in the body without having the progesterone, because our ovaries make estrogen and progesterone.
So guaranteed someone right now is typing on saying, well, wait a second, my birth control pill has estrogen in it.
That's
Is
right.
this going to cause endometrial cancer?
No, because your birth control pill has estrogen and progesterone in it.
Right.
And same person is typing right now, what about my mom who's on hormone replacement therapy,
Great question.
postmenopausal? Is that going to cause that cancer?
Typically not. And if you have a healthcare provider who's prescribed your mom or you with a hormone replacement therapy for your menopausal symptoms, they will know. If you have your uterus in place, you need to have some form of progesterone. So that can either be a pill, or sometimes people put in a Mirena IUD because that's local progesterone, and that protects from that unopposed estrogen effect. So now if you've had your uterus removed and you're on hormone replacement, then you don't need to worry about that progesterone piece.
Okay.
And you can be on just estrogen alone.
Okay.
And that's the thing. So the estrogen makes your lining of your uterus grow. But if you didn't have the progesterone, it just keep growing and growing and growing, and that increases your risk of the tumor.
Yeah.
So you stop the estrogen, you start the progesterone, that causes the sloughing, which is your period, and then you start it over again.
Exactly.
Otherwise, you'd be all uterus all the time.
Yeah.
All endometrial lining.
Yeah, all endometrial lining. Okay, so these are the symptoms we told you about. You go to your doctor. Your doctor's going to do a physical examination.
That's right.
Take a history.
Yeah, usually an ultrasound will be ordered, and then usually an endometrial biopsy. Now that's done through a speculum exam. So a speculum is placed into the vagina, the cervix is visualized, that's the opening to the uterus, and then using a very small pipelle, they'll place it into the uterus and get a sample. If that sample is not adequate, or if they can't do it for some reason, then you might need to go to the operating room for what's called a DNC, a dilation and curettage, where they sample the uterus.
Some cells. Okay.
Yeah.
Okay, so we've done the tests, and we've got the diagnosis. What are the treatment options?
So then usually you'll be referred to someone like me to be
All this is before we get to meet you.
Yeah, exactly. Okay. And then we will counsel you depending on what the pathologist tells us. And actually what's really exciting about endometrial cancer is we're learning so much more in terms of the molecular classification of endometrial cancer. And so we are able to personalize the treatment of endometrial cancer so much more today than we could in the past because of this.
Treating everybody the same.
Exactly, because of these molecular classifications of endometrial cancer. So for that, actually, the pathologist does a lot of work on the back end, someone you will never meet. And they give us a report, and then we kind of act on the report. So typically we will offer you a hysterectomy, meaning a surgery to remove your uterus.
So you can't just remove the lining where the problem is, because it's kind of everywhere.
Generally not.
Okay.
If you are very young and you have a very specific type of endometrial cancer, like a very early, slow-growing one.
Right. And you said, I want to have a baby.
There are fertility-sparing options or options to preserve your uterus so that you can actually, it's funny enough, it's the Mirena IUD that we talked about. So it's progesterone.
Right.
And so we would put the IUD in. You could also take a progesterone pill. Yeah. But I find the Mirena works much better because you set it and forget it. Yeah. And then we would follow you and repeat that endometrial biopsy.
Okay. But that's a small percentage of
That's a very small percentage. We might also use that for a very elderly patient who is maybe not eligible for surgery.
Because it's too big of an operation.
Or risky if they have heart disease, like really bad heart disease, someone who's really frail. But that's, again, a very small, select number of people.
So hysterectomy.
For the large majority of people, we can cure you with a hysterectomy.
Okay. What about the ovaries and the fallopian tubes?
That's right. So those also get removed. It's part of the staging. And we also do a technique called a sentinel lymph node procedure, where we inject a special dye into your cervix. And that helps us map the lymph nodes on each side of your pelvis. And we kind of pluck out 1 or 2 lymph node on each side. This is also an advancement in endometrial cancer. Before, we used to take out all the pelvic lymph nodes on each side, which was quite risky for people in terms of, like, it's more surgery, you've got important blood vessels, you have important nerves, and it causes lymphedema, which unfortunately is swelling legs that you cannot really cure in any way. It's lifelong. So doing these sentinel lymph node procedures where we take out 1 or 2 lymph node on either side gives us the information that we need to know.
Right.
And
essentially for distant cancers.
Exactly. Yeah, exactly.
Okay. So in addition to surgical excision, is there any role for chemo or radiation, or not necessary?
Yes. So depending on the molecular classification and on your stage, you might be offered radiation, and that might just be a small amount of radiation, something called volt brachytherapy, meaning you just get a couple of really small doses at the top of the vagina. Right. You might get external beam radiation. That's where you get outside radiation for about 5 weeks. Or you might get chemotherapy. You could get radiation and chemotherapy. And actually, again, new in endometrial cancer is immunotherapy, is hot
Amazing.
Yes.
I think the future for sure for a lot of
cancers is, and so we do have immunotherapy drugs in endometrial cancer. So again, depending on your molecular classification and on your stage, you might be offered immunotherapy. Now, that's not going to be offered to everyone, but speak to your gynecological oncologist or your medical oncologist, and they'll let you know if you're eligible for it.
Okay. So generally speaking, if it's caught early-ish, people do well?
People do very well.
Okay.
Yeah.
All right. So, and like we said, the great thing about it is it's telling you it's there real early with the abnormal bleeding. Get that checked out, and then you can get the treatment, because like many, many cancers, the earlier it's detected and treated, the way better the outcome.
Wow. I feel like I've learned so much today.
Yeah, we put you on the hot seat.
Definitely. But now you know, if you like this video, please like it, subscribe to our channel, check out our podcast, and share this with someone that you know maybe is dealing with these kind of issues.
And remember, you are in charge of your own health.
And thanks so much for coming today.
Thank you for having me.
Okay, we'll see you next time.